state. And so I do primary care, obesity medicine, culinary medicine, and lifestyle medicine. So love talking about kind of this intersection of food and health. We'll talk about meds as well. So the question of why I'm here, basically I grew up loving to eat. That is my first hobby, and it is still my favorite hobby. I just love to eat. That love of eating grew into loving to cook. And so then I ended up spending a lot of time doing that growing up. Went to medical school, and in medical school, really missed cooking and decided so much so that I wanted to make food a part of my career as a physician. And so then I went to culinary school, came back, finished up medical school, and have been working to combine those ever since. And so there's this growing field called food is medicine, in which we really don't shy away from medications, but feel that food is extremely powerful and underutilized both in preventing and treating diseases, both chronic and otherwise. So there's a part of the field of food is medicine called culinary medicine, which some of you may be familiar with, but I'll tell you most people are not. Culinary medicine is basically this combination of culinary arts, nutrition science, medical education, and we use it to prevent and treat diet-related disease using teaching kitchens. So we have a teaching kitchen here at Yale, I'll tell you about in a minute. There are physical teaching kitchens and virtual teaching kitchens, both. And both can be used, and both have been studied to be really highly effective in helping people translate nutrition information into their daily lives. So we don't think that this is the one and only solution to chronic disease management and prevention. Of course, like I said, we think medications are important. But as you can see here, if we really want to help patients prevent and treat chronic disease by empowering them to follow a nutritious diet, this is not just culinary medicine and teaching kitchens. This is regular visits with primary care physicians, psychiatrists, if necessary, thinking about dietary counseling with a registered dietitian. I'm sure you spend a lot of time referring to them. But really, all of this is predicated on having access to healthy food and having time to prepare it, right? So these are barriers for a lot of people. And I wish I could tell you today that I have all the answers, that we've studied it and I can fix all of that for you. But of course, that's just really not the case. As a sociologist would say, I always tell my students, systemic problems require systemic solutions. And so in culinary medicine, we have individual solutions. We can help people save time and money and give them ideas about what to cook. But really, we need systemic solutions to make food more accessible and more affordable to folks here in the United States. So I'll do the best that I can within those constraints. So just to give you a flavor of why I'm interested in this, what my work kind of looks like, what is a director of culinary medicine? We have this YNHH teaching kitchen, which is in North Haven. It opened not last year, 2 years ago now. Beautiful space where we teach a lot of folks. I work with a great team. I'll just point out Max Goldstein. He's a chef and a registered dietitian, very cool combo. And he teaches all of our patient classes. I'll tell you about those in a minute, but we also teach lots of trainees, which is what I spend a lot of my time doing. So we have physician associate students in the teaching kitchen every year. We teach the medical students. We have 6 classes in the next 6 weeks or so. All of our primary care residents come through once a year. All of our pediatric residents come through once a year. We have our surgery residents during their research year, and I'll say they are better cooks than most of the internists. We have a lot of nurses coming through, as well as faculty in continuing medical education. We do lots of team building and wellness classes. And so if you're ever interested in coming to the teaching kitchen in that format, just reach out. We're happy to set something up. But like I said, we also teach lots of patients in the teaching kitchen. And so this is kind of the cornerstone of our program. And like I said, really helps translate nutrition knowledge into action. And we've seen patients lose weight, put their diabetes into remission, improve their functional status. They're having fun cooking new things they've never cooked before. You see this woman here who told the news, she's like, I'm 75 years old and I've never cooked tofu. And now I'm buying it for me and my husband every week. So really just kind of fun stuff like that to see lives positively changed in the teaching kitchen. I'll tell you more on how to refer to the teaching kitchen later. All of the classes are offered totally free to patients. It's funded through Yale New Haven Health and Philanthropy. So it's a really, really cool resource for the community. So I want to make this information, though, all applicable to the work that you do. So here's my best attempt. So we know that there's a connection between the presence of psychotic disorders and poor quality dietary patterns. It's been shown that that association is both with a higher, what are these poor quality dietary patterns? Higher intake of total fat, and the fats that are taken in through the diet are of lower quality, meaning we have fewer intake of polyunsaturated fats like those omega-3s and omega-6s. Lower intake of fiber. Where do we get fiber from? Vegetables, fruit, and whole grains, right? And so we see lower intakes of vegetables, fruits, and higher intakes of refined carbohydrates, kind of the opposite of whole grains. And then vitamins and minerals of interest in psychiatric and mental health conditions, vitamins B12 and 6, folate, vitamin C, zinc, etc. So these are kind of some observational associations that have been shown in the literature. But there's actually good research also on diet and first episode psychosis, which I know may be more applicable to the work that you do. And so this was a meta-analysis, a systematic review and meta-analysis that you may already be familiar with. 59 studies included in this. All of these studies were RCTs. They focused on interventions that educate patients on exercise or its psychotherapy, where it's focused on diet and physical activity. So interventions really focused on lifestyle and exercise. The patients who were included were those with schizophrenia spectrum disorder or first episode psychosis. And the results really were striking. And again, this is a lot of patients through all RCTs, 59 studies. So really quite an impressive paper showing an association between these lifestyle interventions and lower BMI, waist, circumference, and weight, reduction in the severity of psychotic symptoms, and improvements in measures of cognitive domains, physical functioning, global function, quality of life. And I thought it was interesting that interventions that included exercise education were actually more impactful than psychotherapy only interventions, with the caveat that the psychotherapy only interventions had a higher follow-up rate. So all of this to say, we know that there's a connection between diet and mental health, and then specifically between diet and first episode psychosis. Providing diet and lifestyle education and psychotherapy seems to be really effective. So I think step one, if we want to kind of incorporate that into our practice, is understanding what it means for a diet to be healthy. What does a diet or dietary pattern look like that does not increase our risk for morbidity or mortality, right? And so this is very confusing. There's research coming out all the time that shows that, the results are really conflicting. Patients are confused about this. I know providers and physicians are confused about this. And so this causes a lot of confusion in classes that we teach both for patients and our healthcare professionals. And so what I like to do is I like to bring us all into the same page. We've all heard of these evidence-based diets, right? Everyone knows and loves the Mediterranean diet. It's kind of through this famous or perhaps infamous PREDIMED study. It's a lot of fruits and vegetables. We know about the salmon, the wine, things like that. You've heard of the DASH diet, which is super effective for lowering blood pressure. Everyone knows and loves or loves to hate the USDA My Plate, right? There's a slightly, I think, more evidence-based version of this that a lot of folks in the nutrition community like, called the Harvard Diet Healthy Eating Plate, which, as you can see, looks very similar, but emphasizes that grains should be whole grains and that proteins should be lean or quote unquote healthy proteins. There's no dairy on the side because the Dairy Council does not support the nutrition source through the Harvard Diet Healthy Eating Plate. So that's an optional component. And then you'll see different verbiage: choose versus limit versus avoid in this plate here, which is emphasizing the level of evidence and how strongly we believe it impacts health. So really, really great resource for you and your patients both, the nutrition source, which is through Harvard's T.H. Chan School of Public Health. And then, of course, the whole food plant-based diet, which through Netflix documentaries and other research has become really kind of like the diet du jour. So a lot of people are familiar with this. The big difference is that all protein is plant-based protein. There's no eggs, there's no fish, there's no meat. And then in its most extreme form, there's no salt, there's no oil, no sugar, right? So for a lot of patients, perhaps not the most accessible. I certainly feel that way, and I'm a physician, right? So all of these evidence-based diets have a lot in common, right? These diets are mostly the same things, right? And these things that I've highlighted here, what are they? Plants, right? So we know that evidence-based diets are really, really focused on plants. And everyone knows plants are healthy, right? They're low in calories and for this reason considered to be anti-obesogenic. They help to fight inflammation and prevent atherosclerosis. They actually can help prevent cancer because they're high in antioxidants and naturally low in nitrates, which are some compounds that are added to processed meats and to help preserve our food. And they're not addicting. I love broccoli, but broccoli is not addicting, right? And that's because this combination of sugar and fat together lights up your brain. And it's found all the time in our modern food environment. It's found nowhere in nature. We have some high fat plants like avocados, coconuts. We have some high sugar plants, right, like fruits, but that combination of sugar and fat not found in nature. And so it really lights up our brain. And then when you add in salt, sodium chloride, which is also not found in nature, it really is just hard to resist, right? So plants do not have those characteristics. So they're hard to overeat. So not surprisingly, plants have been associated with a lot of positive health outcomes, preventing cancer, preventing type 2 diabetes, overweight and obesity, cognitive decline, which I think people sometimes don't remember, cardiovascular disease, of course, and then, of course, mental health. So that's like kind of a basic overview of what's healthy. I'm sure a lot of what I'm telling you, you're like, yes, we understand plants are healthy. And then I think it can be helpful to kind of look at the opposite end of the spectrum and say, okay, we know plants are healthy. What is unhealthy? And I think a lot of times meat is villainized, right? But really, I'm here to tell you about the unhealthiest diet in the world, which is the standard American diet. So the standard American diet, we eat about 500 calories more per day than our bodies need. So this excess consumption of energy, as we know, is converted to fat, which can have lots of negative health outcomes. We eat a lot of red and processed meats, which according to the World Health Organization are carcinogenic. So red is probably carcinogenic, and processed red meats are considered to be carcinogenic, again, through those nitrates that we talked about before. We eat a lot of ultra processed foods. Actually, the New York Times right now, starting today, is doing like a 5-day wellness challenge all about ultra processed foods. Some of you may have seen that. And the reason they're doing that is because this term ultra processed foods is quite new. It was only developed or defined in 2012. And since then, there's been a huge burst in the research into ultra processed foods. So we'll talk a little bit more about those in a minute. But generally, some of their characteristics are they have lots of sodium, which of course raises our blood pressure. They're high in fat, especially saturated fat, which improves shelf life. And we know saturated fat increases our LDL and can predispose to atherosclerosis and all of the diseases associated with that. Tons of sugar, right, in these foods. Salad dressings, something I love. I would love to not have to make homemade. I would love to be able to buy a salad dressing off the shelf at the grocery store, but they all have sugar in them. I don't want a sweet salad dressing. I want a salad dressing without sugar. They're very hard to buy. Pasta sauce. I don't really want added sugar to my pasta sauce. You can't buy it. So the sugar is everywhere, even in places where you don't want it. Lots of refined carbohydrates, very few whole grains in our ultra processed food supply, lots of refined carbohydrates. And then if you look at that and you say, okay, that's the standard American diet, what is missing? Plants, right? So we know plants are important. And in our standard American diet, which is largely ultra processed foods, we're really not getting a lot of plants. So just very briefly to tell you what ultra processed foods are, because I know this can be kind of like a confusing terms for some folks. Again, I mentioned it was defined in 2012 via this NOVA classification. So there's 4 different groups of foods. And as you can see, group 1 are like, just things you pick off the tree, or like you take a fish and that fish is an ultra processed food. You cut off part of the cow after it's been slaughtered. Like these are group 1, unprocessed or minimally processed foods. Going all the way over to group 4 are ultra processed foods made of food additives and substances, and they're also called industrial ingredients, right? So if something is made of powders and liquids and starches and other chemicals that are man-made in factories, combined together, fried, packaged in a really brightly colored package, right? These are our ultra processed foods. They're quite new in modernity. We have a lot of these ultra processed foods, but only newly so. And they make up actually more than half of our daily calories. So 57%, almost 2/3 of the calories that we eat every day come from ultra processed foods as adults. And it's much higher for our children. So for children, it's over 2/3 of daily calories come from ultra processed foods. And this is really what we think is driving a lot of the negative health outcomes in our country. And as you can see, we consume a lot of ultra processed foods compared to almost every other country on earth. So why are ultra processed foods unhealthy? Kind of the opposite of all the reasons that plants are healthy. So ultra processed foods are very high in calories and they don't fill you up. They're considered empty calories. If you eat a lot of sugar, it doesn't make you feel full, but it sure gives you a lot of energy, right? A lot of calories. So for these reasons, ultra processed foods are high in calories and contribute to obesity. That sugar is actually directly damaging to our endothelial lining, right? So that's why people have high blood sugar, have a lot of cardiovascular events, right? So eating a lot of sugar can be damaging in that way. It can lead to inflammation and atherosclerosis. The sodium nitrite that I touched on before, which is in processed red meats, is known to be carcinogenic, right? And so bacon, and lunch meats, and salamis, and other cured meats and things like that. And then they are addicting, as I mentioned, because of that combination of sugar, fat, and salt, and that is by design. That is by design. So these foods, unsurprisingly, have been associated with all the opposite things. So they lead to increased cancer risk, cardiovascular disease, type 2 diabetes, cognitive decline, weight gain, and obesity, of course, and negative impacts on mental health. So not terribly surprising. So, where does this leave us? I like to emphasize in our teaching kitchen and when I do my lecturing on a plant forward dietary pattern. I did not come up with this term. Honestly, it's not my favorite term. Like, what's forward versus backward, right? What this means is that there's a lot of plants, right? So, this is a style of cooking and eating that emphasizes plant foods, so whole or minimally processed plants. But you don't have to only eat plants. That might be the healthiest, but we know that that's not necessarily that practical for a lot of patients, right? And so a plant forward dietary pattern emphasizes eat as much plants as you can, and then feel free to supplement it with a few ultra processed foods, with a little bit of animal based protein and things like that. But we still want you to enjoy food and enjoy life, but really emphasize that when you're getting the health benefits from your food, it's almost universally coming from plants. And these types of diets, plant forward dietary patterns, like the ones I emphasized earlier, have been repeatedly shown to improve morbidity and mortality. So the kind of tenets of that, lots of fruits and vegetables, less of these ultra processed foods. Take saturated fats and swap them out for unsaturated fats. So saturated fats are found in dairy and in meat and in things like palm kernel oil, coconut oil, palm oil, things that we see in lots of ultra processed foods, right? So if you cut out saturated fat and replace it with unsaturated fat, we know that that lowers your cholesterol and actually improves mortality as well. Refined carbohydrates, swap those out for whole grains, which include the bran and the germ, the parts of the grain that have micronutrients, healthy fats, and most importantly, fiber, right, to attenuate blood sugar spikes. So opt for whole grains. Minimize added sugars. There are very few things that everyone in the nutrition community can agree on. Everyone agrees that the less added sugar, the better. Decreasing dietary sodium, which is of course good for blood pressure. And all of us essentially eat too much salt. The average American eats about 3,500 milligrams per day, and optimal doses would be like 1,500 to 2,300 milligrams per day. So we eat, roughly 1.5 times to double or more what we should. And that's just on average. Plant-based protein has been shown to decrease mortality compared to animal-based protein. The jury is still out whether that's the protein itself or whether it's the associated saturated fat that comes with animal-based proteins. And then the ratio of what we eat is really important. So these plates I showed you earlier, what do they all have in common? Half the plate's about fruits and vegetables, a quarter of the plate is whole grains and starches, and a quarter is lean protein. So that's what a dietary pattern that is plant forward looks like. I have given you a lot of info in a short period of time. And I'll tell you that when I like to organize this information for my learners, this is how I present it. I'm like, if the only thing you remember is this is the important part. We know that plants are healthy, whole and minimally processed plants. So that's fruits, vegetables, whole grains, nuts, seeds, and legumes. We really know that ultra processed foods are damaging to our health. There's a lot of caveats to that. We know that not all ultra processed foods are created equal. We don't know the exact mechanisms through which it is. Is it the specific ingredients? Is it like the matrix of the actual food itself, which has been made easier to digest? Is it the starches, which are interrupting the gut microbiome? There's a lot of hypotheses out there and more research is needed, but we know that these ultra processed foods are damaging. So if you think about these as two opposite ends of the spectrum, wherever you are on the spectrum in a particular day, in a particular week, at a particular meal, in a particular season of your life, the goal is to just try to eat more plants, right? And the more plants you eat, the more it crowds out those ultra processed foods that we know are not necessarily beneficial to our health as much as they may be delicious. So that's kind of like general healthy eating, right? And this same diet is applicable for folks who are at increased risk of cardiovascular disease, diabetes. There's something called the MIND diet, which is specifically formulated to help prevent cognitive decline due to Alzheimer's and vascular dementia. It's the exact same type of diet as this. We know that the same type of diet that's good for all of these health conditions, it's all the same. It's all the same. But when we're talking specifically about weight management, which I know is something of particular concern to you all, given the prescription of antipsychotic medications that you do so frequently, there are some caveats. And so I want to be sure to point those out. One is that a lot of people and a lot of your patients probably suffer from food insecurity, and food insecurity should be addressed really specifically, honestly. So in the United States, about 10% of people are food insecure. Believe it or not, it's slightly higher in Connecticut compared to the national average. And in New Haven, kind of unsurprisingly, it's over double the national average. So almost a quarter of people in New Haven experience food insecurity. I work at 150 Sergeant Drive at Cornell Scott. Many of my patients I know experience food insecurity. This has been associated with diabetes, cardiovascular disease, obesity, and a number of mental health conditions, particularly depression. But we know that food insecurity has these really negative impacts on our health. And we also know that it's not stratified uniformly across race. So as you can see, folks who identify as Latino or Black experience food insecurity at much higher rates compared to white folks, double, triple the rates essentially. And so this is, as I talk about sometimes in my classes with med students, PA students, residents, we dive into kind of the systemic factors and the systemic racism that really plays into this, but just understanding that not all of our patients are affected equally by this, and that these effects are sometimes compounded by those other factors. So when I provide dietary counseling, the first thing I do is screen for food insecurity. And then if someone screens positive for food insecurity, I do not spend my time being like, you should really eat more fruits and vegetables. Like, you should do X, Y, Z, right? It's just like, let's get you enough food. So it's all about referring to resources, because it would be really tone deaf to spend time talking about how to improve a diet if they don't even have enough access to food to support a diet. So screening for food insecurity, you may already be doing this in your practices. Very, very simple. It's built into Epic, at least in my outpatient context, so I'm not sure about yours. But it's 2 questions. The first is, have you ever worried whether your food would run out before you got money to buy more? And in the past year, did you ever feel like the food you bought didn't last and you didn't have money to go buy more? And so patients say this is either never true, sometimes true, or often true. And if they say often true or sometimes true to even just one of these questions, that's considered a positive screen. I will say that a lot of practitioners are worried about asking their patients these questions, worrying that their patients will be offended or that it'll kind of damage the rapport a little bit, or it'll make things awkward. I find that patients are very willing to talk about this, and they are appreciative that we ask. And so if that's a worry of yours, I would encourage you to give it a try and see what you find as well. But like I said, this is step 1. And then if they screen positive, we have caseworkers and managers and folks who can connect them with, food banks and get them signed up for SNAP and WIC and those types of programs. Again, this is where a safety net really has big holes in it, something that I can't really fully fix. But I'll say that this is step 1 of providing dietary counseling. But if you screen your patient for food insecurity and they do not have food insecurity, then the next question is like, which diet is best for weight loss? And I call this the $1 billion question because the diet industry in the United States is a $1 billion per year industry. And what the research has repeatedly shown is that there's actually no difference between all the diets. So regardless of macronutrients, those macronutrients being carbs, proteins, and fats, if you're doing a low fat diet, a high protein diet, a low carb diet, right? Like all these permutations, they all lead to the exact same amount of weight loss in the long term. And the key is that they have to be reduced calorie. So as I mentioned, when we think about counseling folks on a healthy diet, if they're not trying to lose weight, we don't really focus on calories, which is energy, at all. We focus on, like I said, fruits, vegetables, whole grains, nuts, seeds, avoiding ultra-processed foods. For folks in whom you're concerned about overly restrictive eating or eating disorders, again, maybe energy and calories is not the place to focus, and you just focus on the quality of the food. But for someone specifically who wants to lose weight, there's really no getting around the necessity to focus on reduced calorie diets. Sometimes the reduced calorie diets just happen as a result of increasing the quality of the foods, focusing more on those fruits, vegetables, whole grains, nuts, seeds, legumes. But for a lot of folks, they have to put specific emphasis on it. So I want to talk a little bit about that. This is one of my favorite papers. If in the nutrition community, Dariush Mazafarian and Walter Willett are like some of the best nutrition researchers like of all time. And so they collaborated on this paper. It's been cited like 3,500 times in the past decade alone. And what they found was essentially that folks who eat these foods that we know are good for us, right? Vegetables, nuts, whole grains, fruit, high quality dairy like yogurt, they lose weight over time. And folks who eat these ultra processed foods, potato chips, processed meats, sweets and desserts, refined grains, sugar sweetened beverages, juice, they gain weight, right? So the point of saying this is that sometimes by just focusing on increasing the quality of the diet as a natural byproduct, folks will lose weight. And so if you can lose weight with a watermelon diet or like a cabbage soup diet or, a raw food diet, why would you do that when you can lose weight and improve the quality of the foods that you're eating to support your metabolic health at the same time? So that's my pitch. But the way to do this specifically with regard to weight loss is you really have to focus on energy density. And so this is probably not a novel concept to many of you, but if you look at this top picture, each of those bowls contains 100 calories, right? So you look at jelly beans on the left, dried fruit, and then whole fruit, right? And then I think those are tomatoes on the right. So which bowl do you think will leave you feeling the most full for the longest period of time, right? It's about high volume eating. And when you eat foods that per volume have a low amount of calories, that's a low energy dense food, right? And so those foods on the right are lower energy density. So looking at a meal here at the bottom, it's another way to look at that. So that meal on the left has 800 calories, the meals on the right have 400. So basically, if you're trying to go from an 800 calorie meal to a 400 calorie meal, you could just cut everything in half, right? That's kind of what you see in the middle. Or what you could do is really eat less of the high energy starches, less of the meat, which contains a lot of saturated fat, and really just load it up on veggies, right? And as you can see, you get to eat a higher volume of food when you focus on that rightmost plate, which encourages eating more of those low energy dense foods. So it's really about focusing on the volume of food that you can eat in order to stay full. So thinking about these low energy dense foods, why is their energy density low? They have lots of water and they have lots of fiber. Water, of course, has 0 calories. Fiber is not absorbed by the body. You eat it, it takes up room in your stomach, it stretches your stomach receptors, it says, we're full, we're full. It moves its way through the digestive tract, and then you poop it out, right? It has lots of beneficial physiologic functions along the way. It promotes the growth of healthy bacteria in your gut. That's its prebiotic function. You may have heard of probiotics, but this fiber functions as a prebiotic also. It, of course, keeps you regular. It kind of along with it, grabs LDL and fats. And so it prevents you from absorbing some of those and you poop it out. So it lowers your cholesterol. So it has lots of benefits, but it's important for weight management because of the fact that it has 0 calories, but it fills you up with volume. In American diets, we eat a lot of empty calories, as I mentioned. These products that contain a lot of fiber and water, these low energy dense foods, they take longer to eat because you're like chewing. Like you can imagine celery, how long that takes you to chew 1 pound of celery versus 1 pound of, jelly beans. It, goes down much faster, the ultra processed foods. And because of that fiber and that water content, it keeps you fuller longer, calorie per calorie. And then we think it probably has some beneficial changes to the gut microbiome that may feed back into helping with weight loss, but those mechanisms honestly still need to be elucidated. But we know it's helpful in many ways. So that's kind of like the science part of this. And now I want to give you some practical tips and tricks. So we did like a 3-part series with the medical students where we spent like an entire session doing like meal planning and grocery shopping and where to find healthy recipes. The second one was on setting up your kitchen, buying the right equipment, how to cook fast, how to prevent needing to do so many dishes, And in the third session, we focused on how to make this sustainable, how to have quick snacks on the ready, how to focus on mindful eating to eat less, how to incorporate the 6 tenets of lifestyle medicine, of which one is diet, so that they co-support each other, right? So these are the practical tips and tricks that we're teaching all of the time, not only in the teaching kitchen, but also to our trainees. And so I want to give you just a highlight of some of those here. And then I'll make sure at the end to leave time for questions. So where can you find healthy, accessible recipes? These are a few of my favorite resources. So there actually is an American College of Culinary Medicine. It was founded last year in February, but the Health Meets Food curriculum that they license has been around since 2012. When I trained at the Goldring Center in New Orleans, I helped to develop that. And really great recipes developed by chefs, physicians, and dietitians. Super cool. So they have a list of all of those on their website, the American College of Culinary Medicine. Something called Budget Bites, which I find, the recipes, some are healthy, some are like decidedly not very healthy, right? So you have to like have kind of a critical eye when you're looking at them, but it tells you the amount per serving. There's a variety of cultural recipes, right? And so it can fit for a lot of patients, different kind of cultural ways of eating, and really made with kind of easily accessible ingredients. So I really like their resources. And then many of you may have heard of this book called Good and Cheap, or in Spanish, it's Bueno y Barato, and both are free. So if you sign up, they used to just be freely available. Now you have to sign up for her newsletter on her website, which is also free. But this woman, Leanne Brown, she was doing a master's in food studies at NYU, one of the best places, I'll say, in the world to do that. And as far as for her thesis project, she made this book where she photographed all the recipes, she developed all the recipes, she wrote all the recipes, and it was designed to fit a SNAP budget at the time, which was about 15 years ago. So they are, as the book says, recipes that are both good and cheap. So super, super cool resource. She's actually coming to do a virtual class with us in March at the Teaching Kitchen. We're very excited. So just a few places for healthy, accessible recipes, also lots of them available on social media. When it comes to saving money at the grocery store, I know this is something on the top of a lot of people's minds these days. These are my top tips. Buy according to the unit price. So make sure to look at that unit price. That way you don't have to look at the total cost of the olive oil, for instance, divided by the number of milliliters and be like, okay, which one's cheaper? You know, right? Just look at the unit price. I think that's really underutilized. Most grocery stores will include both the total price and the unit price. For staple ingredients, I always get the generic and the store brands. I am not buying Bush's beans. I am buying ShopRite beans, Stop and Shop beans, right? So buy generic and store brand when able. If able to buy bulk, so it's something you know you're going to eat enough of, you're not going to throw it away. It's something you use all the time. It's something that's on sale, something in bulk. That's, if possible, a really great way to save money. Buying things in season, peaches are much cheaper when they're in season compared to other times of year, right? So shopping in season. Shopping on sale, using coupons if for things you're buying anyway. You know, don't look at the coupons and be like, oh yeah, maybe I could buy that since there's a coupon. No, buy things that you're going to buy anyway, but use coupons. Use canned and frozen, which I'll talk about in a minute, and then plant-based proteins in place of animal-based proteins. And so I always tell this story of like, this seems like kind of simple, right? And you're like, okay, that's not going to solve this for my patients. So growing up, my dad was a blue-collar worker and my mom was a stay-at-home mom. And I have like really vivid memories of every Tuesday night. She would take all of the ads for all of the grocery stores in town. She would kind of plan out the meals for the week. She had this big black Sharpie, and then she would go through all of the sales. And for the things that she needed, she would circle it in a big Sharpie. And then she would take all of these ads to Walmart where they did price matching. And then she would buy those ingredients, show them the ad, and then they would price match it. And between that and coupons, we never experienced food insecurity. And we had a variety of homemade meals that were really health promoting. And I'm not sure that we would have been able to do that without kind of that savviness. And so it may seem silly to be like, oh yeah, buy things on sale, use coupons. But with the right know-how and with the right dedication, it can really, I think, make the difference for a family, because I saw that with mine. Great. So that's saving some money at the grocery store, but I am a big fan of also using grocery store shortcuts. So I went to culinary school. A lot of chefs will basically tell you like, oh, I would never buy pre-bought butternut squash. You know, it's like a matter of pride. And so when like your patients are watching people on TV, they're like, I would never use dried herbs, you know, and like not helpful to patients like ours, right? And so there are a lot of grocery store shortcuts that I find myself using all the time, and I think we can really take a lot of pride in, right? So if you can buy fresh, pre-prepared ingredients, saves you a lot of time. This is the only way. I buy green beans frozen, and I buy them like this. I never buy like frozen green beans that have to be trimmed and washed myself. I buy them this way, right? Not a lot more money. So these are just some coleslaw. I never pull out my mandolin to shave a cabbage, right? It's just ridiculous. So buy fresh, pre-prepared ingredients when able. And when they're going to expire, like in the next couple of days at the store, they become really, really cheap. So if you're going to buy a coleslaw mix and make it that day and eat it, buy it, right? What's the harm? We in the Teaching Kitchen emphasize frozen pre-cut ingredients. I just did an interview with the New York Times, and they're like, what is the number one tip you have for eating healthy in the new year? I was like, buy frozen food, because it's so much cheaper. It keeps forever in the freezer. And these produce picks, they're picked at the peak of ripeness. So it's not like your apple, or no, that's not a good example. It's not like your avocado that's picked like 2 weeks before it's meant to ripen and shipped to you, right? And it's this hard avocado, it hasn't ripened, right? They're picked way before they're ripe. For this type of stuff that's going to be frozen, they pick it at the peak of ripeness and they flash freeze it. So it is more nutritious, actually. So this frozen produce, more nutritious many times than fresh produce. So I really encourage folks to use, especially these combo blends that are used. Imagine how easy a stir fry is if you just buy the frozen mix, right? Or this mix for soups, or this mix for fajita bowls, which we do a lot in the Teaching Kitchen. So buy frozen, pre-cut ingredients, and canned. You know, I don't buy everything canned. You know, I much prefer frozen or fresh corn compared to canned corn. But there's a lot of canned ingredients that are just as good or even better. You know, tomatoes are good for like 2 months out of the year here in Connecticut. The other 10 months, the canned are going to be better. They're going to be higher quality, right? Lentils, you can boil lentils dried for 20 minutes if you want, or you can just buy them in a can. Beans, you can let them soak overnight if you want, or you can just buy them out of a can, right? I will never buy a pumpkin, roast it, and then take the pumpkin out to use in my pumpkin bread recipe, right? Buy the canned pumpkin. Same with artichoke hearts. I am not going to go through all that work. So really think about how you can use these canned ingredients. And the other two I have up here are canned fish. Canned tuna is fabulous, but people forget about salmon. You can buy canned oysters, actually clams. Like this stuff is really tasty. So don't hate on it. And then this canned evaporated milk is a huge, I think, key in the kitchen. Lots of recipes that we see online that people that go viral call for heavy cream. So if you buy evaporated milk, that's not sweetened condensed milk, it's evaporated. So all they do is they take fat-free milk, they evaporate off some of the liquid, and you end up with an evaporated milk that's thicker and creamier, but still has no fat, right? So it's a huge plus when you're making baked goods or other kind of creamy dishes. So just a few ingredients that I would really recommend getting in cans. To spend less time cooking and cleaning, cross-utilize ingredients. So chop your onions once, put them in the fridge, use them all week. Buy a rotisserie chicken, delicious meal that night, but then you can make dinner, some tacos, soup, stock, chicken salad, cook in bulk, freeze the leftovers. I'm a single dude, and so like I cook maybe 3 times a week, and then I don't want to eat the same thing every day, like 7 days in a row, right? So I will make a full recipe and then freeze half so that weeks when I'm in the hospital working like I was last week, I can just like unthaw things and eat those. So really, that's one of my biggest tips. The New York Times loves sheet pan recipes, but everyone loves sheet pan recipes or one pot meals. And so really focus on those if you want to do less dishes, because actually the worst part of cooking is not cooking, it's the dishes that come afterwards. And then this was the biggest hit with the med students, microwave meals. A lot of them live in dorms actually where they do not even have access to a kitchen. So it's like microwave meals or Uber Eats. So you can make sweet potatoes in the microwave and load it up with a little canned vegetarian chili, delicious. Cauliflower rice you can buy in bags, microwave it, and then add some pre-made curry sauce. Egg scrambles, delicious. So like a little bit of frozen vegetables, eggs, a little bit of chili oil or Calabrian chilies, some pesto, really truly delicious and easy to do. Canned salmon with rice, and the rice again you can make in the microwave. You can take normal rice and make it in the microwave, or you can buy the minute rice, which is not different in any way other than they've parboiled it and poked holes in it. So it's partially cooked, so it cooks faster when you're at home. A spaghetti squash with marinara sauce, easy go-to this time of year, and oatmeal, which you can do both sweet and savory. So I encourage folks to use the microwave, honestly. A lot of opportunities there. These are some of my favorites. I don't know when they appeared on the supermarket shelves. I first started noticing them about 5 years ago. They are so good. So each of these packs is like $1 essentially, and they cook in the microwave in like 60 to 90 seconds. And the ingredients are super simple. It's like this Cuban black beans is like vegetables, spices, beans, chicken stock, essentially. It's like wild how truly like good for you they are, and they are shelf stable. So when these go on sale, I stock up on them. I keep them in my pantry, and then they can easily be combined with, like I said, the minute rice or with a cauliflower rice or something like that. You can have a microwave meal that's really, really delicious in like 3 minutes. So highly recommend these. And then, of course, snacks, everyone's favorite. So I am a salty snacker. A lot of people are sweet snackers. And so I'm going to give you kind of some options for both. But sweet snacks, I think these are some good options. I think we forget about applesauce, which they sell in single serving cups, right? So just get some unsweetened applesauce. Fruit cups, they also sell like this. Look for ones that are in their own juice, not with heavy or light syrup, right? And then, of course, the savory snacks, which are my favorite. So these harvest snaps, if you haven't seen those, delicious and super good. So much fiber, really natural ingredients. I highly recommend. And they're in these bags that are around 350 calories per serving, which is a pretty sizable snack, but they're quite filling because, like I said, they take a long time to eat because of all the chewing you have to do, and they contain all that fiber. So really delicious. What else do I want to mention here? These chickpea snacks, roasted chickpeas, they turn out really well in your air fryer. If you have an air fryer, like a lot of people do, take just like, I would say less than 10 minutes, just olive oil, salt, pepper, whatever dried spices you want, garlic powder, onion powder. It's really delicious. Or you can buy them in a bag like this. Dry roasted edamame, similar story. Reduced fat wheat thins. Wheat thins are 100% whole grains. They contain no refined grains. Pretty impressive for how good they taste. And the reduced fat versions are kind of exceptionally crispy and can be good with some packets of tuna. So that's a few ideas for some nutrient dense single serving snacks. And then I want to make one caveat about meds, and then I'll take questions. So this has largely been about lifestyle and diet. So that's my culinary medicine chef hat. So I'm going to take that off, and I'm going to put on my obesity medicine doctor hat, which is largely focused on medications. The caveat, this may be something that as clinicians you're already doing. And if it is, you're probably going to be like, okay, great. I'm glad this guy told me about that. If this is something you're not doing, then I'm curious to hear what your thoughts are. But essentially, if we know that it's easier to prevent weight gain than to lose it once you've acquired the weight, which we know, the body fights against you to lose weight. It thinks you're starving, right? So it makes you crave high calorie foods. It makes you feel sluggish so that you burn fewer calories. Your body really doesn't like it when you lose weight. So it is easier to prevent weight gain than it is to lose weight once you have it. We know that these antipsychotic medications can promote weight gain and impair insulin sensitivity. And we know that you can treat these things, weight gain and insensitivity, both with diet and pharmacotherapy. So we know these things to be true. Well, therefore, when we start to antipsychotic medication, ideally, we would provide dietary counseling to prevent weight gain, to preserve insulin sensitivity, but we would also initiate pharmacotherapy. And so when I was studying for my obesity medicine boards, it recommended actually starting metformin at the same time as antipsychotics. That is something I had never learned before in medical school. And the research is quite good to support it. So as you can see, these are the most recent guidelines from the American Association of Clinical Endocrinologists and the American College of Endocrinology for folks with obesity. And so for folks who are receiving antipsychotic medications, they recommend co-treating at the same time with metformin. And there's been really good research in this, both in these kind of meta-analyses of placebo-controlled RCTs with children, with adolescents, with first episode of schizophrenia. The research is quite good. Like basically, if you initiate metformin at the same time as like olanzapine, for instance, folks gain less weight and they have improved insulin sensitivity. So it's such a cheap medication. It's covered by like everyone's insurance. And if you can kind of mitigate some of those effects of the antipsychotic medications, so prevent the weight gain in the first phase, prevent the insulin, the decrease in insulin sensitivity, I think that's a really easy and exciting, prospect. And so metformin is not FDA approved for weight loss, but we find in the research that it leads to about 3% weight loss. So if you are, trying to prevent people from gaining 5% or more of their weight, that sometimes 3% can go a long way. And it's, I think, worthwhile in a lot of patients. So curious what your thoughts are on that, but just wanted to make that caveat at the end that diet and exercise can both be important. This is my last slide, so I'm just going to wrap up. The Teaching Kitchen referral process. You can feel free to scan this QR code. I wish it was a little easier to refer than it actually is. These are the caveats. You have to be a Yale provider. So you have to be like a Yale dietitian or clinical psychologist or an MD or a DO or a nurse practitioner or a PA, essentially. And several of those providers require a co-signature on the referral. MDs and DOs, obviously, you don't have to have a co-signature, but the referral must be placed through Epic. And it must be for a patient who's affiliated with Yale New Haven Health. But if that's the case, so if you're a psychiatrist and you see patients, even if it's at the CMHC and you have access to Epic and the patient's record in Epic, you can refer them through Epic to the Teaching Kitchen. The classes are totally free, as I mentioned. The process is you put in the referral, someone calls them. We set them up with an intro class, which is where we do knife skills, kitchen safety, intro to a plant-forward diet. We make some basic tacos, essentially, in several different ways with varying levels of plants. And then if patients want, they can never come back again. They can be like, okay, that's just really not for me. Most patients do come back and they can take up to 5 more classes. And the classes are focused on breakfast, lunch, dinner, snacks, and full menu ideas. So they can take up to 6 classes that we offer in the Teaching Kitchen, again, totally free of charge. And they can kind of schedule them in any order and at their own pace. So it's not like they come once a week for 6 weeks. They can be like, oh yeah, I want to take one in March. I want to take one in June. And they can set them up in that way. Most of the classes are in the evenings from like 5 to 7:30. So that works really well for patients. For those who want to come during business hours, we offer classes on Wednesday afternoons. As I mentioned, they're taught by our chef registered dietitian, Max Goldstein, who's fabulous. And then occasionally we offer virtual cooking classes for community members. So folks who don't have a Yale provider or folks who do. And those people can sign up for it through the Yale New Haven Health website by just searching Teaching Kitchen, and then upcoming classes will be listed under events. So I'm sure you have more questions about that, but I'm actually happy. I'll wrap up here, and then I'm happy over the next few minutes that we have left together to take questions about any of that or any comments you have.